Hello friends, Namaskar. I know you have already completed the main videos of all the 19 subjects from Cerebellum. I know you have also gone through the live mission program sessions of all the 19 subjects from the Cerebellum app, and it is now the time for a comprehensive revision. What better than the Cerebellum's rapid revision course? So here I bring to you PSM, one of the key subjects for your upcoming examination. I am your very own Dr. Vivek Jain. Friends, what I have done is I have kept the sequence of topic exactly like I have done in the main videos. I have done in the live mission session videos also. So this will help you get a structured schedule for a comprehensive revision of PSM. So let us start with today the first topic, that is epidemiology. So epidemiology, let us start with the basic definition. Friends, what exactly is epidemiology? It is a combination of three parts, that is epi among, demi people, and logy study. So can I say it is study of people or population? No, that is known as demography. So this is not study of people or population, but we study something among people or population, and that is, yes, diseases. So epidemiology is study of diseases, and we study this in three separate parts. What are these three separate parts? This includes distribution, determinants, and frequency. Now, distribution of disease. Distribution. A disease may be distributed in time, place, or person. So time is the seasonal distribution, place is the geographical distribution, and person is according to age or sex of the person. When we look at determinant, this is the most important part in the definition, causative agent. And frequency we measure as incidence, that is number of new cases per 1000 population at risk, it's a rate, and prevalence, that is total number of existing cases, new plus old, divided by total population into 100. Incidence is a rate, but prevalence is a proportion. This definition was given by epidemiologist John M. Last. Now, the major purpose of epidemiology is to find a causative agent of a disease. So, let's take the classical example of smoking leads to lung cancer. Smoking is the risk factor, lung cancer is the outcome. So, we will have to first make a hypothesis, that is possibly smoking is the cause of lung cancer. So, how can we test this hypothesis? We will have to use epidemiological studies. Now, epidemiological studies are broadly divided into two groups. These are observational studies and experimental studies. Observational studies, in which you only observe, is further subdivided into two types of studies: descriptive studies, where you only describe, and analytical studies, where you analyze, and experimental studies, where you give an experiment or intervention, are interventional studies. Now, first let us look at what are these type of epidemiological studies are meant for. What is their use actually? Descriptive studies are used for hypothesis formulation, making a hypothesis. Possibly smoking is the cause of lung cancer. How we can do this? We can do this by taking any small study design. Only thing, that hypothesis should be made in time, place, and person. Possibly lung cancer, which is the second most common cancer of male population in India in 2024-25, is caused by smoking. So it has time, place, person besides risk factor and disease. After you have made the hypothesis, you have to test it also. Here is where analytical studies come. So analytical studies are used for hypothesis testing. How will you test your hypothesis? You can test it by using one out of the 4 different study designs. These are cohort study, case control study, cross-sectional study, and ecological study. So after you have made a hypothesis, tested your hypothesis, now it is finally confirmation time for your hypothesis before you tell the population. Interventional studies are used for hypothesis confirmation. Now how will you confirm your hypothesis? By experimental or interventional study designs, trials. So this includes clinical trials, RCTs, randomized controlled trials, community trials, and field trials. So make a statement, test your statement, confirm your statement. So let's try to understand these study designs by taking them one by one. So can you identify this is which study design? We are starting with the exposure. Look at the direction of the arrow. We are going towards the event or the outcome. So very right, this is a type of cohort study. Now when you look at cohort study, if you see carefully, starts with the exposure and non-exposure group. That could be smokers, non-smokers. And then we go in a forward direction. So if I take 2025, 100 smokers, 100 non-smokers, and I want to see whether this smoking leads to lung cancer, I'll have to wait 10 to 15 years. Let us wait for 15 years. 2040, I will check how many of them develop lung cancer. Let us suppose 80 develop lung cancer in the smoker group. At the same time, 10 develop lung cancer in the non-smoker group. So this is my cohort study. I am starting from exposure today, going in a forward direction till the outcome occurs. So this is known as forward-looking study, also known as prospective study. Similarly, cohort study is also known as cause to effect. We are starting with cause, going towards the effect study, risk factor to disease study, and exposure to outcome study. Because we are going in a forward direction every year, so we do a follow-up of all these study subjects. So this is a follow-up study, and every year, because we get number of new cases, cohort study is also known as incidence study. Now doing a cohort study is not just sufficient, you have to calculate your results. Results are calculated by the strength of association. So what are the strength of association? How strongly smoking and lung cancer are associated with each other. How do we calculate? Very right, as discussed in main videos and mission videos, strength of association we can calculate by 3 parameters. These are RR, relative risk, AR, attributable risk, and PAR, population attributable risk. Let us take same example to understand the concept. So what is relative risk formula? It is incidence of a disease in exposed divided by incidence of the same disease in non-exposed. Look at this question. Incidence in exposed, 80 develop lung cancer in 100 people exposed to smoking. Incidence in non-exposed, 10 develop lung cancer out of 100 people not exposed to smoking. So relative risk in this study is 8. Now besides formula, calculation, now the interpretation. What is the meaning of relative risk 8? Smokers have relatively 8 times higher risk of development of lung cancer as compared to non-smokers. Relative risk is also known as risk ratio. So ratio of risk of development of lung cancer between smokers and non-smokers is 8:1. Now please remember, relative risk may come more than 1. Like in this example, then we declare association is present. But if by chance it comes equal to 1, we have similar incidence of lung cancer in both the groups, then there is no association between smoking and lung cancer. There must be some other risk factor. Then relative risk will come less than 1. This is negative or inverse association. That means risk factor is in fact protective or beneficial for the disease in question. Now in the same example, attributable risk. Let us look at formula first. It is given by the formula incidence in exposed minus incidence in non-exposed upon incidence in exposed into 100. So this will be 80 by 100 minus 10 by 100 upon 80 by 100 into 100. So this will give us a value of 87.5, roughly let us say 88%. Now what is the meaning of attributable risk 88% in the same study? How much of the disease can be attributed to risk factor? 88% of lung cancer can be attributed to smoking. 88% of lung cancer is due to smoking. 12% must be due to some other risk factors which we don't know, we cannot comment upon because we are not studying those risk factors. Attributable risk is also known as absolute risk, excess risk and risk difference also. Now PAR, population attributable risk, this is given by the formula incidence in total minus incidence in non-exposed upon incidence in total into 100. Now what is incidence in total in this particular study? Total 90 develop lung cancer out of 200 people minus incidence in non-exposed upon incidence in total into 100. So this will be roughly 7 by 9 or roughly 77%. Now friends, what is the meaning of population attributable risk? If risk factor is modified or eliminated, how much reduction in annual incidence of disease will occur in the population? So for the same question, relative risk 8, smokers have 8 times higher chance of lung cancer as compared to non-smoker. Attributable risk 88%. 88% of lung cancer is due to smoking. In the same study, PR is 77%. If smoking is eliminated from this population, there will be an annual reduction of 77% incidence or new cases of lung cancer every year, but other 23% cases will keep on occurring, right? Now, when you look at relative risk, this is required by you as a clinician. But if you are an epidemiologist, you will focus on attributable risk. But when you have to decide whether to start a program or not start a program, if you are a public health program manager, then population attributable risk is the one that you will look at. Overall, if you see the best strength of association, single best answer, most accurate, simplest to calculate, easy to understand, that is relative risk. Now let us look at this particular study design. If you see here, direction of arrow is backward. We are going from disease to the risk factor. So this is backward looking study, or yes, case control study. When we do not have so much time like 15 years to conduct a cohort study, we do it in a very fast backward direction, case control study. Now look carefully, we are in 2025. I take 100 lung cancer cases. Cases are who are having the disease. For comparison, I take 100 healthy people, control group. Then I look backward. From 2025, if they are having the disease, risk factor smoking may be present 15 years ago. So I shift the design 15 years ago and I ask them by history, how many of you were smokers in both the groups 15 years ago? So this backward looking study is also known as retrospective study. And because direction is just opposite to cohort study, all its name would get reversed. So case control study is also known as effect to cause study, disease to risk factor study, outcome to exposure study. We don't do follow-up, we don't get incidence, but it is also known as Trohock study. This is just to indicate it is exactly opposite in direction to a cohort study, also known as case reference study. Now, what are the advantages of case control study over a cohort study? It is quick because you just have to take history. So, logically, it is cheaper also. But it comes with a big problem of recall bias. People may not be able to remember their history correctly. Here you don't get incidence every year. So, we are forced to calculate strength of association. We cannot calculate RR, AR, PR, which are based on incidence or new cases every year. Here we are not getting them. So, we calculate strength of association as odds ratio. So, how do we calculate this odds ratio? We need to get a 2x2 table depicting history of the risk factor and the disease on the same table. Let's look at that. And in this table, this is your A, this is your B, C and D. Now, if you look at disease is present in A and C, so we can say first column is cases and B and D don't have the disease. So, second column is controls. Now, in this particular case control study table, now you are in a position to calculate strength of association odds ratio. What is the formula for that? This formula is AD by BC. Now, if you look carefully, A into D divided by B into C, we are doing a cross multiplication. So, odds ratio, which is the strength of association in a case control study, is given by cross product ratio from the table. Now, it is also a strength of association like we have relative risk in a cohort study. Formula may be different, but its meaning interpretation is same. So, odds ratio may come more than 1. Declare association is present. If odds ratio comes equal to 1, no association is present, it must be having some other risk factor. And if odds ratio comes less than 1, this is negative or inverse association. Risk factor is in fact beneficial or protective for the disease in question. Now, if odds ratio in a study comes 21, what does it mean? That lung cancer cases have 21 times higher odds or chances of giving a history of smoking as compared to healthy people or controls in the past. Now, friends, we have understood that cohort study takes a lot of time, but its relative risk is more accurate. Case control study is faster, cheaper, but due to recall bias, its strength of association odds ratio is less accurate. So, if I want to have advantages of both, I want to calculate relative risk also, and at the same time, I want to save my time also like a case control study. I will combine the two designs, and combination of these two designs is known as, yes, retrospective cohort study. Let's look at that. So, just to revise, prospective cohort study, smoking today, lung cancer after 15 years, we are going in a forward direction. So, we are able to calculate incidence and relative risk. But because it takes a lot of time, we do it in an opposite direction, where we start with disease lung cancer first. Then we go back in time and ask history of risk factor smoking. So 2025 we start with lung cancer. 10 years ago history of smoking we ask. We don't have incidence relative risk. So we are able to calculate odds ratio, which is slightly less accurate due to recall bias. So when we combine both the study designs, that is known as retrospective cohort study. We cannot go forward, we cannot go backward. So how is retrospective cohort study done? First we go back in time and find out smokers and non-smokers from hospital records 15 years ago, 2010. Then we don't know how many of them are having the disease. Then we follow them up to current time and see how many of them have developed disease till today. This way, I am going in a forward direction. So I will get incidence relative risk. But I am also not spending 15 years of my life. So it will save my time also. This particular study design, which combines advantages of both, is known as retrospective cohort study. And if you combine both these together, that is known as mixed cohort study. You did a retrospective cohort study, taking the hospital records, finding smokers, non-smokers from 2010 data, and then you follow them up to current time 2025 to see how many of them have developed the disease. So you are going in a forward direction, you will get incidence relative risk. Your retrospective cohort study is completed. Now someone takes your study for another 10 years and he or she wants to see in 2035 what will happen to the final incidence of lung cancer. Will it change? Will it remain same? So this will be an addition of prospective component to your retrospective cohort study. So this is known as mixed cohort study. Now if you notice carefully, what is the hallmark of a cohort study? It is always in a forward direction. Exposure to outcome. Exposure to outcome. The moment it goes in a backward direction, it becomes a case control study. So cohort study, cardinal hallmark, forward direction, temporality. Case control study is backward in nature. Another combination design of cohort and case control study is nested case control study, which is generally done for a new rare disease which is having very expensive diagnostic test. We are in 2025. There are 10,000 births in your hospital. Healthy births. We take their history and store it in the computer, and we take their samples, blood, stem cell, urine samples or any other as per requirement, and store it in the refrigerator, freeze it -25 degree. Then forget them. Now follow these newborns. We follow them up for 5 years. Nothing happens. Another 5 years, nothing happens. Another 5 years, nothing happens. But another 5 years, that is when 2045, all of them become 20-year-old. Suddenly there are 50 new cases of a rare disease. Now if you see carefully, you are having how many healthy people now? You are having a total of 9,950 healthy. From them select 50 controls. Now you have material ready for a case control study. These 50 cases and controls, come back and compare history and do a case control study. If you find some difference in some history, make a table, odds ratio more than 1, that is the risk factor. If there is no difference in history, compare the samples, any parameter different in samples between cases and control, that could be a possible risk factor. This is a nested case control study where a small case control study, if you see carefully, this is nested in a big cohort study. So 10,000 births for 20 years, big cohort study. A small case control in that, only 50 cases, 50 controls. Nested case control study is definitely cohort plus case control study. But if they ask you a single answer, it is mainly a type of cohort study because its major direction is forward, temporality, temporal association, cause to effect. it still consumes 20 years of your life. So look at this particular diagram. This is a type of, very right, this is retrospective cohort study. Now you tell me guys, why this is a type of retrospective cohort study? Because study begins here when outcome has already taken place. But look at the direction of the arrow. We are still going from exposure to outcome. So how we must have found the baseline exposure? We must have taken that from hospital records. So 2010, you took hospital records, found out smokers, non-smokers, then follow them up in forward direction till they develop the disease. That is till 2025. This is a retrospective cohort study which has incidence relative risk calculation possible but saves time also. This is, yes, exactly the example we took. Look at this. We first take initial data and we are taking specimens also. Then from this population, we are going in forward direction for years. When people develop disease, they are labeled as cases, and people who don't develop the disease, from them we select controls. Then we are going in a backward direction to do a small case control study where we can compare history or specimens. So this is a type of nested case control study. A combination of cohort and case control study, but mainly a type of cohort study because it shares the common property of temporality or temporal association. Now let us look at these 5 study designs that we have discussed till now. Look at design number 1. This is, yes, prospective cohort study. Because you are here, you go in a forward direction, disease will occur. But look at study number 2. You are here. So you can start with disease and go in backward direction and ask history. So this is a type of case control study. Look at study number 3. You are here. You first go backward, take hospital records, from that find exposure, non-exposure, then come to current direction. So this is retrospective cohort study. Look at study number 4. You are here. You go backward, find out smokers, non-smokers from hospital record, come to current time. You do your study and then someone adds a prospective component and takes your study further. So this is mixed cohort study. And finally, look at study number 5. You are here. You keep on going in forward direction. When disease occurs, then you come back and check their history and blood specimen. So this is a nested case control study. So image based questions you should be able to identify. Study designs have been asked in recent papers, that also you should be able to identify. This is a type of, yes, multiple studies are analyzed together. So can I say this is a sort of analysis of analysis. So very right, this is mainly yes, meta-analysis. Multiple studies are analyzed together. Now meta-analysis has several advantages. You do quantitative synthesis of all the results. So this is the best study design, most superior study design. It is kept at the top of evidence-based medicine pyramid also. This meta-analysis has disadvantages also. How? That it has apple and oranges effect. Different studies you are trying to mix, they may have been done in different settings. GIGO principle, garbage in, garbage out. Only the quality of meta-analysis result will be based on the quality of the studies that you have selected originally. And of course, it may have file drawer effect or publication bias. Right friends? This is EBM, evidence-based medicine pyramid. Now, as we have discussed, in evidence-based medicine pyramid, what is kept at the top of pyramid is meta-analysis. So, meta-analysis is kept at the top of this pyramid always. If you cannot do meta-analysis, go for systematic review. Not possible, randomized control trial. Not possible, cohort study, case control study, cross-sectional ecological. And then comes opinion, views, beliefs, research. Bottom of the pyramid is in vitro. Gold standard of evidence-based medicine has to be meta-analysis again. Best study design. And who is known as father of evidence-based medicine? That is David Lawrence Sackett. Evidence-based medicine. What is this known as? If you look carefully, friends, what is being shown here? Stage of susceptibility, subclinical disease, clinical disease, finally recovery, disability or death. So this is showing progression of a disease without any intervention. This is known as, very right, natural history of disease. Now study this diagram slightly carefully, friends. They may ask you any particular point, like this particular point has been asked in your examination. So subclinical disease to clinical, in between is going to be onset of symptoms, then only we will be able to detect the disease in the person. What is this known as? Yes, this is absolutely same. Progression of disease without any intervention. So natural history of disease. In this natural history of disease diagram, you can see an inverted triangle in the center. This is known as epidemiological triad. So first stage is where there is exposure. After that, there is an interplay of agent, host, environment, epidemiological triad, and then finally pathogenesis start, that is leading to clinical horizon. It may go up till death, or if person is lucky, there may be a spontaneous recovery, either complete or with disabilities. So period of pre-pathogenesis, if you look carefully, this is the period where we can apply primordial level of prevention before emergence of risk factor, primary level of prevention when risk factors have emerged but disease has not yet taken place. But once the disease starts, we have to shift to diagnosis and treatment, secondary level of prevention. And finally, if the patient has disease in progression, we should attempt for disability limitation and rehabilitation through tertiary level of prevention. Now, one organism may lead to a disease, that is germ theory of disease given by Louis Pasteur. But look at this particular example. This is which theory of disease causation? This is web of causation. Multiple factors may also cause a disease, like coronary heart disease may be caused by smoking, alcoholism, stress. But when these factors are related to each other like a spider's web, this is known as web of causation. So, multifactorial causation, Pettenkofer gave this, but web of causation theory was given by McMahon and Pook. And what is the exact use of using this web of causation model? This tells you the potential interventions which are possible for prevention and control of a disease in a population. So we have already seen three factors are required for a disease to occur: agent, host, environment. This triad is closed because interaction is required between them. If you look at epidemiological triangle, that is also exactly same. We have agent, host, environment. But it has an additional fourth factor in the center, that is time. Now in advanced model of epidemiological triangle, what is different is causative agent is replaced by causative factors. Host is same, human being, single, family or as a community, and it says not just environmental factors are required for disease to occur. Many places we have nutritional factors, social factors, genetic factors, cultural factors, psychological factors, and definitely in this center is time. So triad has three components, triangle has four components, and advanced model also you can say has almost four components. This is, yes, spot map. In a spot map, what does each spot depict? Each spot is actually one case of the disease. This spot map was originally used by, yes, John Snow for the disease cholera spreading in London. Therefore, John Snow came to be known as father of epidemiology and also father of modern epidemiology. Cholera disease came to be known as father of public health. Now, the type of epidemiology which was used by John Snow for finding the source of infection in London for cholera, that was shoe leather or gumboot epidemiology. And the type of study design which was utilized by him was natural experiment study design. Please remember, spot map actually shows you not state wise, not district wise, not national or international, not rural urban, but it shows you only local variations for a particular disease in a geographical area. Now looking at some stalwarts in epidemiology, we have number 1, Louis Pasteur. Now Louis Pasteur is credited with, yes, germ theory of disease. He also gave the concept of pasteurization of milk. Sir Louis Pasteur also coined the term vaccine, and he actually developed many important vaccines, out of which two you have to remember: anthrax and rabies vaccine, besides the chicken cholera vaccine. Now, Louis Pasteur, a French scientist, died in France. When we look at second image, this is of Sir Edward Jenner. Sir Edward Jenner is credited with, yes, discovery or development of first vaccine, and that was, yes, the smallpox vaccine. He also coined the term vaccination. So, whereas Louis Pasteur was known as father of modern microbiology, Edward Jenner was known as father of immunology. Third image we have already discussed, John Snow. father of epidemiology, modern epidemiology. Edward Jenner died in the year 1823. John Snow died in the year 1858. On the left side of your screen is James Lind. What is his contribution? No, it is not scurvy. It is not vitamin C. He discovered and postulated that citrus fruits are useful in prevention and treatment of scurvy. Scurvy which used to be so common in sea sailors. Image on the right is Sir Robert Koch. He has been credited with the discovery of TB bacillus. And he also gave in microbiology Koch postulates. He also discovered cholera and anthrax bacillus. This diagram is yes forest plot. Useful in studies like meta-analysis. In this particular diagram, you can see we have different studies along with their results depicted on the same diagram. So we have 5 different studies where name of the person or the researcher who conducted the study along with the year in which it was published is mentioned. On the diagram, we depicted the results of these studies. In this particular example, we have depicted their odds ratio. So these must be 5 different case control studies. In them, we have given not only their odds ratios, but for 5 studies, we have also given their confidence interval. As we have discussed in main videos and mission videos, if confidence interval includes 1, then results are not significant, not valid. So study number 1, 2 and 3, if you see, confidence interval includes 1, their results would not be useful. But study number 4 and 5, their confidence interval do not include 1. So therefore results are valid. They should be included for calculation of the final result. And the final result is depicted in the same diagram, the synthesized quantitative result of meta-analysis. That is known as the diamond measure. The summary measure is known as diamond measure or diamond. Now, if I look at this particular diamond, you can see the diamond has 2 edges on side. These are confidence interval. It has a central value, that is the quantitatively synthesized result, which was 2.2 in this particular example. What is this particular diagram known as? Now, if you look carefully, in this diagram, we have a box in which there is a line in the center, and on this side are 2 whiskers. So this is very right known as box and whisker plot. Now friends, what does box and whisker plot used for in epidemiology and biostatistics? Friends, box and whisker plot is representation of data in its quartiles. So if you look carefully, this is quartile 1. This central line in the box is quartile 2 and this is quartile 3. So we have minimum value at the lower end and maximum value at the outer end. And if you find some values outside, those are yes outliers. Now look at this particular diagram which is showing 4 different types of box and whisker plot. Look at number 1. If you see carefully, it appears to be bilaterally symmetrical. So definitely this is normal distribution. Look at number 2. It also appears to be symmetrical, but it also has these outliers. Now look carefully at graph number 3. Here you can see the longer line is going towards left or negative side. So this is left or negatively skewed distribution. Now look at the fourth graph now. Here the longer line is going towards right or positive side. So this is right or positively skewed curve. Box and whisker plot is also known as candlestick chart. Tools of measurement of epidemiology: rate, ratio, proportion. In rate, numerator is a part of denominator. Multiplier is not 100. It may be 1000, 10,000, 1 lakh. Like incidence, new cases out of total population at risk into 1000. Incidence is a rate. But look at prevalence, new cases out of total population into 100. When numerator is a part of denominator, multiplier is 100, it will always come in percentage. So prevalence is a proportion. Case fatality rate is a proportion. Secondary attack rate is a proportion. But look at sex ratio, number of females divided by number of males into 1000. Here numerator is definitely not a part of denominator. So numerator, denominator are not related to each other. Sex ratio is a type of ratio. Now we move to the unit health and disease. We first look at time distribution of disease. Now what is time distribution? It could be studied in three types. These are short-term fluctuation, long-term fluctuation, periodic fluctuation of a disease. Short-term fluctuation of a disease fluctuates in a short time. That short time is days, weeks or months. This is popularly known as, very right, epidemic, earlier known as outbreak. Long-term fluctuation, a disease which takes decades to slowly increase or decrease in the population. This is known as, yes, secular trend of a disease. Periodic fluctuation occurs again and again repeatedly. This is of two types. If it occurs every season, then it is seasonal trend of a disease. If it occurs after every few years, that is cyclical trend of a disease. Food poisoning is a type of, yes, that is an epidemic. Staphylococcal food poisoning, most common food poisoning, incubation period 1 to 6 hours. Maximum people eat food within a marriage. After eating contaminated food, maximum people fall sick within 6 hours. Bhopal gas tragedy was an example of, yes, epidemic. 3rd December 1984, population was exposed to methyl isocyanide. Chernobyl tragedy, yes, again an example of epidemic where population was exposed to radioactive isotopes of cesium, strontium and iodine. And Vizag tragedy during COVID epidemic in India is also an epidemic where there was leakage of, yes, styrene gas. But if you look at communicable diseases, they are slowly reducing in India. At the same time, problem is non-communicable diseases are slowly increasing in India. And this has been going on since last 40 to 50 years. It has not occurred in months. So this is secular trend of a disease. Seasonal trend of a disease could be malaria, dengue. Rainy season and after that due to mosquito breeding, these cases increase. Respiratory diseases in winters, heat stroke in summers, asthma, hay fever in spring season due to pollen or winter. These are seasonal distribution. Cyclical trend of a disease could be something like measles, which increases once every 2 to 3 years. Or it could be like rubella, a disease which increases once every 5 to 8 years or 4 to 7 years. But maximum cyclical trends of a disease is shown by influenza because it has maximum antigenic variations, antigenic drift which occurs due to point mutation, antigenic shift which occurs due to gene recombination, reassortment, rearrangement of genes. Now when we look at types of epidemics, then this is, look carefully, there is a sudden rise in number of cases, and when treatment is started there is a sudden fall in number of cases. If you look carefully at the bottom, this red bar indicates there is a clustering of cases in one incubation period of the disease. So this is a type of single exposure point source epidemic. Please remember, food poisoning is a good example of single exposure point source epidemic. Bhopal gas tragedy, Chernobyl tragedy, Vizag tragedy, they are very good examples of single exposure point source epidemic. Now compare this epidemic type with the second type of epidemic. Here you can see the rise is sudden, but fall is not sudden. It is interrupted by multiple peaks. These multiple peaks are known as secondary waves. Now can I say exposure is occurring only once? No, exposure is occurring multiple times. Is it occurring from a single point source? Yes, like a contaminated well or a contaminated pond. So this is multiple exposure point source epidemic. So multiple exposure point source, also known as continuous or repeated exposure point source. Point source is also known as common source. So not just contaminated well in a village. A good example could be any STD like HIV. When it is spreading through a commercial sex worker, that commercial sex worker will act as a point source, giving multiple exposure to the same client community again and again. But if you don't look at commercial sex worker, let's look at HIV or STD. Now don't look at HIV through a commercial sex worker. How does HIV spread in the population? It has a very slow rise in the population. Why slow rise? Because it is person to person transmission. One person, if he has two partners, will give rise to two cases. If they have more partners, it will become 3 or 4. So this slow rise, slow fall, and sometimes even peak is not there. This third type of epidemic is known as propagated epidemic. Now we come to the concept of epidemic. What is epidemic? When number of cases of a disease is in clear excess of normal expectancy. So when cases are more than normal expectancy. How are you going to measure it quantitatively? That is by the formula, if cases of a disease are more than mean plus 2 standard deviations. So it may not be always a large number. Even a small number could be an epidemic. So reoccurrence of a eliminated or eradicated disease, even new disease would be counted as epidemic. Then what is endemic? Endemic is a disease which is always present in the population. So continuous presence of a disease in a population. Majority of diseases are endemically present in the population. The image shown here, this is pandemic. Now what is pandemic by definition, friends? Pandemic is country to country spread of a disease. Now the biggest pandemics are COVID-19 and HIV. Otherwise swine flu, bird flu have been also big pandemics. And finally their fourth counterpart is sporadic. What is a sporadic disease? Sporadic disease any type of poisoning, any type of snake bite, one case here, one case there. Cases are scattered in time and place, logically person also. Now just for a quick recap, look at these two diagrams. First is this, which type of time distribution this is. You have to just carefully look here. First peak is here, second peak next year December January, next year December January, next year December January, next year December January. So it is occurring every year December January. This is a type of seasonal distribution of disease. Compare it with this particular diagram where you can see the disease is increasing every 5 to 6 years, a disease like rubella. So this is cyclical trend of a disease in a population. So concepts have to be strengthened along with the images. Levels of prevention. How many levels of prevention exist, friends? Very right, these are 4. Primordial is applied before emergence of risk factors. Primary level of prevention is applied after risk factors. So risk factors present, but luckily no disease yet. We can still prevent the disease. Secondary level, disease possibly started in the body. Now you can only diagnose or treat. And tertiary is applied when disease is in progression or it is over in the body with or without sequelae. Now how we are going to achieve these levels are through its modes of intervention. What are these? Primordial is through health education. Primary level is through health promotion specific protection. Secondary level, diagnosis and treatment. And tertiary level is disability limitation and rehabilitation. Please remember, primary can prevent the disease or the outcome, whereas secondary can only detect, it cannot prevent the outcome. So question usually comes in the form of an example, like if you are asked measles vaccine, BCG vaccine, tetanus toxoid, rabies vaccine, human papilloma virus vaccine. Vaccines are only taken when a risk factor is present. So vaccines by default are primary level specific protection. Exception could be BCG when it is used as a treatment modality in bladder carcinoma. Then it would go as secondary level of prevention treatment. Look at contraceptives like condoms, OCP, IUDs, or even sterilization. Contraceptives are used when a risk factor is present, so they are also primary level specific protection. Any test like peripheral blood smear, sputum smear for acid fast bacilli, chest x-ray, blood culture in typhoid, these are mainly used as a diagnostic test. So they will go in secondary level diagnosis. When we look at DOTS, directly observed treatment short course, treatment of tuberculosis, MDT, multi-drug therapy, treatment of leprosy, artesunate based combination therapy with sulfadoxine pyrimethamine, drug of choice for malaria. These are treatment modalities, secondary level of prevention. When you look at mosquito nets, mosquito repellents, they are used when mosquitoes are present, risk is present. So mosquito nets, repellents are again primary level specific protection. But how can you prevent emergence of risk factor mosquito in the environment? That will become primordial. That is source reduction, elimination of breeding places of mosquitoes. No larva breeding, no mosquito will occur. Spectacles are, yes, tertiary level of prevention. Spectacles provide disability limitation also, rehabilitation also. Please remember, disability limitation never occurs alone. If it is occurring, because spectacles is stabilizing your visual acuity number, it will not fall. Automatic visual rehabilitation will come. You can see each alphabet clearly. Compare it with intraocular lens. Intraocular lens is used for treatment of cataract. So this is secondary level of prevention, just like LASIK. But when we look at contact lenses would be again tertiary, just like spectacles, disability limitation and rehabilitation both. When we look at crutches in polio, they do not limit the disability. They are also tertiary, but only rehabilitation. Physiotherapy will provide both disability limitation and rehabilitation. When we look at seatbelt helmet, they are primary level specific protection. So seatbelt helmet, they cannot prevent accident, but they can give specific protection against head injury. Monitoring of blood pressure cannot prevent hypertension, but it helps in early diagnosis, secondary. Fetal ultrasonography cannot prevent Down syndrome, it can detect. So this is also secondary level, like chorionic villus sampling, amniocentesis. When we look at mobile eye clinic, they cannot prevent cataract or refractive error, it can only detect. Therefore, this is also secondary level of prevention. Preserving traditional lifestyle is primordial. A father asked his son not to adopt bad habits, primordial. A father asked his son to change his bad habits, risk factor is present, primary health promotion. A son actually changes his habits, bad habits, on advice of father. Now it is primary level specific protection against an adverse outcome, right? So before risk factor, after risk factor, early part of disease, late part of disease, primordial, primary, secondary, tertiary. Apply the definition, mark the answer. Overall, best level of prevention for non-communicable diseases is primordial. Major risk factors, smoking, alcoholism are totally preventable. When we look at tuberculosis, best level of prevention is early diagnosis. Leprosy, early diagnosis, so that we can start prompt treatment. Overall, best level of prevention is primordial. Prevention of emergence of risk factors. Folic acid started 3 months prior to planned conception. Usually we give it in a dose of 4 milligram. That is, risk factor is present, history of neural tube defect. So this is primary level specific protection. Just like iron, folic acid, just like immunization, contraception. Spectrum of disease. Spectrum of disease has 4 components. Arrange them in correct chronological sequence. First is disease, then impairment, then disability, and finally is handicap. How question comes in the exam? They'll give you an example and then ask, this is which part of spectrum of disease? Disease we know. What is impairment is loss of any anatomical physiological, psychological function or part of the body. Because of this, disability occurs. What is disability? A person is unable to do routine activity. What is routine activity meaning? Routine activity means which a person of similar age or sex can do. And finally, what is handicap? If a person is unable to perform his role in the society. What is the role in the society? Earn for himself, earn for family and contribute to the society. Now first question, a person loses right hand in a truck accident is a type of. Okay, let's look at this. See, road traffic accident is a disease. Because of this, a person loses right hand. This is an impairment. Because of this, person cannot drive his bike. He cannot write properly if he was a right hander. And because of this, he is thrown out of his job, he is unemployed. So, cannot drive, cannot write will be disability and unemployment because of this will be a handicap. So, question asked in our paper, loss of right hand in a truck accident is a type of, yes, impairment. 27-year-old male unable to perform sexual activity considered normal for his age and sex is a type of, yes, disability. All of us know diabetes mellitus is a common disease. Elderly males, it may lead to erectile dysfunction. So, erectile dysfunction is impairment. Because of this, person has no sexual activity. This is a type of disability. Can it lead to divorce in India? Yes, you have read in forensic. If it results in divorce, that would become a handicap for that person or family. So, absence of sexual activity considered normal for age or sex is known as a disability. Definition wise, types of cases. Cases are of three types: primary, secondary, index. When we look at primary case, what is a primary case? Primary case is a case which is first. So, first case of a disease in a community. Secondary case is not second case. These are all cases who get infection from primary case or develop from primary case. And primary case could be 1, 2 or even more also. What is an index case? A very fairly commonly asked question. Index case is first case which comes to the notice of investigator. Or you can say first case diagnosed by the health system. Another set of definitions, what is incubation period? It is a time period between entry of organism in human body till appearance of first sign or symptom. What is median incubation period? Time taken for 50% cases to occur in a community. Serial interval has to be an interval. It is an interval or gap between what and what? It is a gap or interval between primary and secondary case. Here secondary case is second case. So, it would also be approximately, may not be exactly, similar to incubation period. What is generation time? This is time taken between entry of organism in human body till maximal infectivity. Now, what are the different types of carriers we see in epidemiology and communicable diseases? Contact carrier, a carrier who develops from a case or who gets infection from a case. Paradoxical carrier, what is a paradox? It is a person who becomes infected from another carrier. Incubatory carriers shed organism even in incubation period. Convalescent carriers shed organism even in convalescence or recovery phase. Chronic carrier usually is who sheds organism more than 6 months. So less than 6 months would be acute carrier, and pseudo carrier never says not a carrier. It is also a carrier, but he is a carrier of a virulent organism. Nothing to worry. No manifestations will be there. When we look at quality of life or development in a country, we use two indices, PQLI, HDI. Physical quality of life index. Index is a combination of indicator. It is a combination of three indicators: literacy rate, infant mortality rate, and life expectancy at 1 year of age. Human Development Index is also a combination of three indicators. First and third are same, literacy rate and life expectancy. But this is LE0, life expectancy at birth. Rather, IMR is replaced by income in this. Now, please remember, literacy rate is known by several synonyms: education index, mean years of schooling, and enrollment ratio or knowledge. All are same. Similarly, please remember, income is measured either as per capita or US dollar purchasing power parity, comparison of income currency between two countries. Life expectancy is also known as longevity. Now, when we look at their ranges, please remember, quality of life lies between 0 to 100. Whereas Human Development Index of a country lies between 0 to +1. When we look at India, India's Human Development Index is currently above 0.64, having a rank of 132. Switzerland is most developed country, Human Development Index 1 in the world. For Human Development Index calculation, please remember, minimum maximum value of life expectancy goalpost we take. Minimum we take is 20 years and maximum we take is 83.4 years. Unit vaccines and cold chain. We first start with MI, Mission Indradhanush, where the mission or the main aim was to immunize 100% coverage for all children in the country by the year 2020. For this, initially we targeted 7 vaccine preventable diseases. These are severe forms of TB through BCG, diphtheria, pertussis, tetanus, polio through OPV, hepatitis B through hepatitis B vaccine, and the disease which causes maximum morbidity, mortality among VPDs, that is measles vaccine. Now, while this program was underway, 4 more vaccines were introduced in the program: Japanese encephalitis, IPV, rotaviral vaccine, and MR vaccine. And subsequently, 2 more vaccines came into picture, that is pneumococcal conjugate vaccine and Haemophilus influenza vaccine. So, if we look carefully, 7 plus 4 plus 2, a total of 13 vaccines giving a coverage against 12 diseases have been carried out through this Mission Indradhanush, a primary level specific protection. Currently, IMI, Intensified Mission Indradhanush 4.0 is going on in the country. What is this, friends? This is VVM, Vaccine Vial Monitor. What does VVM tell you, friends? Can I say it is a marker of expiry date? No, that is printed on the vaccine. Viability of organism or efficacy of vaccine? No. It is a marker of cold chain maintenance. If you look carefully, there is a white square in this center and a blue circle outside. Blue circle remains blue. It is the white square in the center which changes color. In grade 1, what happens if vaccine is maintained in proper temperature? Inner square will remain white. But if temperature starts changing, it starts going towards the higher side, then in grade 2, inner square will become light blue In grade 3, it will become blue. Many times the margins of the square disappear. It looks like a circle only. And in grade 4, it may become even darker, purple or black. Based on WHO guidelines of VVM, a vaccine vial is usable up till grade 2. If it is grade 3 or 4, discard the vaccine. So please remember, up till grade 2 we can use, or another way of saying same thing, I can say, based on vaccine vial monitor, a vial is usable if inner square is lighter than the outer circle. If it becomes same color or darker, discard the vial. This VVM is also an indirect marker of potency. Nowadays, we are using diacetylens for preparation of VVM. Earlier, p-toluene sulfonate was used as a VVM chemical. VVM is of 4 types in the country: 2, 7, 14 and 30, used from very heat sensitive to very heat resistant vaccines or heat stable vaccines respectively. Now when we look at VVM, this is the sequence of color change. Please remember, grade 1, 2, 3 and 4. So 1 and 2 are definitely usable. But if inner square becomes same color or darker, discard the vial. So VVM2 preferably should be used for most heat sensitive vaccine. Most heat sensitive vaccine is reconstituted BCG, followed by yellow fever, followed by OPV. Whereas this VVM30 is used for least heat sensitive vaccine, or you can say more heat stable vaccines. These would include T series of vaccines: DPT, DT, TT, hepatitis B. Please remember, tetanus toxoid is the most heat stable vaccine. This is, yes, the global switch program. And what did we switch from? All countries of the world in April 2016 switched from trivalent OPV to bivalent OPV, because polio virus type 2 was eradicated on 20th September 2015. Trivalent OPV earlier used to consist of all 3 types of polio viruses, P1, P2, P3, but then P2 was taken off and bivalent is now P1 and P3. All countries of the world together switched. India was no exception. 25th of April 2016 is the National Switch Day of India. Subsequently, on 9th of May 2016 was the National Validation Day of India for the same. Please remember, we are using this bivalent OPV in routine immunization also, pulse polio immunization program also. But IPV of India still continues to be trivalent in the National Immunization Schedule of India. National Immunization Schedule of India latest, it is covered under RCH program, National Health Mission of India. Immunization in India starts at birth and finishes by 16 years of age for both boys and girls. In girls, then it will continue further with each pregnancy. At birth, which vaccines are given? We give BCG, first vaccine of the child. It is then followed by OPV 0 dose, 0 only means at birth, and the hepatitis B. Then we call the child 3 times, 6, 10, 14 weeks, 1.5, 2.5, 3.5 months, where we give vaccines which require multiple doses. So we give first dose of DPT, OPV, Hep B, and then their second and third dose at 10 and 14 weeks of each. We also give Haemophilus influenza B, first, second and third dose. Then rotaviral live attenuated vaccine, first, second and third dose we give. Subsequently also was introduced fractionated IPV, where first and second dose is given at, please remember, 6 and 14 weeks. No dose is given at 10th week. Similarly, pneumococcal conjugate vaccine, first dose and second dose is given at 6 and 14 weeks. No dose is given at 10th week. When we look at pentavalent vaccine of India, it combines 5 different vaccines. These are DPT, hepatitis B, and Haemophilus influenza B. Then we call the child at 9 months of age, where we give him measles vaccine first dose or MR vaccine first dose. It is always given along with vitamin A, which is given 1 lakh international units. Along with that, we also give JE vaccine, that is live JE vaccine SA14-14-2 strain first dose, and we give pneumococcal conjugate vaccine booster dose. A new addition to the program has been the introduction of fractionated IPV third dose at 9 months of age. Then we call the child every 6 months, where we give him again vitamin A, but this time we give him 2 lakh international units each till the child becomes 5 years of age. Subsequently, 16 to 24 months we call the child for booster doses, DPT booster, OPV booster. Also, the child gets the second dose of measles or MR. Please remember, these 2 doses of measles or MR is known as AMR strategy, accelerated measles mortality reduction strategy, inclusion of 2 measles vaccine doses in routine immunization. Then we also give Japanese encephalitis vaccine live second dose. At 5 years, we again call the child for DPT booster. Then at 10 and 16 years, we give tetanus toxoid to the child. Please remember, tetanus toxoid in pregnant female is also a component of national immunization schedule only. Now, latest change in the national immunization schedule, tetanus toxoid at 10 years, 16 years and pregnancy has now been replaced with a combination of tetanus and diphtheria, TD vaccine. If you look at vitamin A, we are giving 1 lakh at 9 months, then 2 lakh 8 times till 5 years of age, giving a total of 17 lakh international unit dose. Delayed immunization limit, BCG can be given till 1 year of age, OPV can be given till 5 years of age, hepatitis B 1 year of age, then Haemophilus influenza B 6 years of age. If you look at rotaviral vaccine, pneumococcal conjugate vaccine, pentavalent vaccine, fractionated IPV, they are given till 1 year of age, JE till 15 years of age. Also look at measles MR till 5 years of age and vitamin A till also 5 years of age in the country. Now friends, when we look at vaccine wise, first we look at the first vaccine given to a child in our country immediately at birth, that is BCG vaccine. It is a type of live attenuated lyophilized powder vaccine. Now these lyophilized powder vaccines have to be reconstituted with a diluent. The diluent that we use for BCG in our country is, yes, normal saline, NaCl, sodium chloride. When we look at dose, route and site, the BCG vaccine is given 0.05 ml, that is after reconstituting BCG powder with normal saline. It is given intradermally on skin above left deltoid. This vaccine carries a protective efficacy of 0 to 80%, median 50%. A total duration of protection it provides is for 20 years. Now, when we look at the strain from which it is produced, that is Danish 1331. Copenhagen strain also. Danish 1331 specifically when we look, this is derived from Mycobacterium bovis and its production requires 239 serial subcultures which is done over a period of 13 years. Guindy Labs near Chennai is continuously engaged in this production. And as I told you, this is the most thermolabile vaccine, most heat sensitive vaccine after it is reconstituted with normal cell line. When we look at similar questions from measles vaccine, it is also a type of live attenuated lyophilized freeze dried vaccine. What is the reconstituting diluent of measles MMR vaccine? That diluent is distilled water or sterile water may also be used. This vaccine measles is given in a dose of 0.5 ml subcutaneous just in right arm. Its protective efficacy is very high, more than 90% with one dose. As I told you, 2 doses are now in the program and efficacy goes above 99%. This highly successful 2-dose strategy is known as accelerated measles mortality reduction strategy. The strain we are using in India is not Suarez or Moreton, but Edmonston Zagreb strain for production of measles vaccine, which is world's first and only licensed malaria vaccine, that is Mosquirix. Currently launched in Africa, available in Africa. This vaccine, which has a protective efficacy of 26 to 50%, is derived from 2 components. What are these 2 components? One is circumsporozoite protein of Plasmodium falciparum and second component is envelope protein of hepatitis B surface antigen. This vaccine, the strain is RTS, S adjuvant AS01. Similarly, a new vaccine which was launched but subsequently withdrawn because of issues related for dengue was Dengvaxia. Live attenuated tetravalent vaccine having all the 4 strains of dengue virus D1, D2, D3 and D4. Do we have a similar sort of new landmark vaccine under trial for leprosy? Yes, that is in India. That is by the name of MIP vaccine. Mycobacterium indicus preni vaccine developed by Pran GP Talwar, National Institute of Immunology. This vaccine is a unique vaccine because it is given along with the dose of rifampicin. If I ask you what is BB152, AZD1222, yes, Covaxin is BB152 and Covishield is AZD1222. So we are now looking at 2 important COVID vaccines introduced and used extensively in our country. When we look at Covaxin, it is a type of whole virion 100% killed vaccine, inactivated vaccine, given in a dose of 0.5 ml. 2 such doses are given with a gap of 4 to 6 weeks intramuscular deltoid. Age-wise, it is used for aged 15 years and above in the country. This vaccine is permitted in both pregnancy lactation and it has a strain also, National Institute of Virology 2020 770 strain. Just like any other vaccine, cold chain requirement is +2 to +8 degree centigrade. When we compare similar thing for Covishield, Covishield is non-replicating viral vector-based vaccine. Ebola was the first such vaccine in the world. This Covishield is based on Oxford AstraZeneca vaccine. Dose 0.5 ml. The gap has to be maintained for 2 doses to be minimum 12 to 16 weeks. Intramuscular deltoid like Covaxin. This is recommended for age 18 years and above in the country. Pregnancy lactation, it is safe, and cold chain temperature is same. When we look at Covaxin, it has been developed by Bharat Biotech. Covishield has been developed by Serum Institute of India, Pune. Now please remember, a unique feature of Covaxin is it is India's first 100% indigenous vaccine. Very little known side effects, whereas thromboembolism and thromboembolic phenomena stroke have been observed with Covishield administration in few. After Covaxin and Covishield, two more important vaccines came into our country. One is Corbevax and another is Incovac. We look at Corbevax first. This is a type of receptor binding domain proteinaceous subunit vaccine. This vaccine given in a dose of 0.5 ml intramuscular deltoid. The gap is to be maintained is 4 weeks between the two doses. This vaccine, which has been developed by Biological E Limited, Hyderabad, has to be given in the age group 12 to 14 years in the country. A unique feature of Corbevax, this can be used as a heterologous booster dose for Covaxin also, Covishield also. When we look at Incovac in comparison, Incovac unique feature, it is first intranasal COVID vaccine. Here the dose comprises of 8 drops, 4 and 4, right nostril, left nostril, 4 and 4. This is one dose. 2 such doses should be given with a gap of 4 weeks in between. Developed again by Bharat Biotech. This vaccine is BBV 154. Also like Covaxin, a unique feature of Incovac is this is India's again 100% indigenously developed vaccine. Japanese encephalitis vaccine given at 9 months of age, 16 to 24 months of age is a live attenuated lyophilized freeze-dried powder vaccine. Reconstitution is done with the diluent phosphate buffer saline. Please remember, rotaviral vaccine, Rotacil vaccine, the diluent is citrate bicarbonate buffer. This vaccine, which is given till the age of 15 years in the country, is having a strain of SA14-14-2. Vitamin A, only non-vaccine in the national immunization schedule because it was the commonest cause. Vitamin A deficiency was the commonest cause of blindness among children in our country. This at 9 months we give 1 lakh international units. Then every 6 months we give 2 lakh each. This continues till 5 years of age. So 9 months, then 2 lakh at 1.5 years, 2 years, 2.5, 3, 3.5, 4, 4.5, 5. A total of 9 doses equaling 17 lakh international unit total dose. This is administered by a specific plastic white colored spoon which has a outer margin of 2 ml and a horizontal inner mark of 1 ml. Vitamin A we have deliberately prepared in India with the strength of 1 ml contains 1 lakh international unit. So health worker knows if the child is below 1 year of age, in a tea mark or in a teaspoon mark full, and if it is a child more than 1 year after infancy, complete teaspoon should be given. So 1 ml at 9 months, 2 ml 8 times, 17 ml or 17 lakh international units as primary level of prevention. Specific protection should go inside the body of the child. Disease with 100% case fatality rate, that is rabies vaccine. So we look at two types of schedules which are followed for rabies vaccine in our country. We have SN regimen. SN regimen is intramuscular. And what is this regimen? This is 1-1-1-1. This is automatically understood that these vaccines are given on day 0, 3, 7, 14, 28. We also have intradermal schedule in our country which goes by the name of Thai updated Red Cross regimen for rabies vaccine. What is this particular Thai updated Red Cross regimen schedule? This is 222-02. Again, 2 doses on day 0, day 3, day 7, and do not call on day 14, directly 2 doses on day 28. So 5 times intramuscular, 4 times intradermal. Person would have to make a visit to the health center or doctor's clinic. This we are talking of is post-exposure prophylaxis. When we look at pre-exposure, a person requires 3 doses on day 0, 7, 21, 28. Now, if such person, veterinary doctor, dog handler, monkey catcher, having a pet in the home, now after immunization he gets exposure, then post exposure in these vaccinated individual, the person requires only 2 doses on day 0 and 3. All these represent primary level specific protection. All of us know human rabies immunoglobulin is better than equine rabies immunoglobulin. HRIG 20 international units per kilogram. Equine is 40 international units per kilogram. This has to be infiltrated as much as possible, 100% around the wound itself. But if it's something left, then that should be given intramuscular in opposite deltoid, opposite to the site of vaccine which has already been administered. Please remember, immunoglobulin is not given if 7 days have elapsed from the first dose of starting the vaccine. Please remember, it is mainly useful in category 3 bites where there are oozing of blood or multiple transdermal bites are there. Now, what is rabies? As the word is telling you, it is 3-dose rabies vaccine. Now, please be careful. As the word is telling you, it must be having 3 doses. So, we will give it as early as possible, day 0, 3, 7. This vaccine, which has been produced by Cadila, is a type of nanoparticle based G protein recombinant vaccine. And I have told you, human rabies immunoglobulin, preferable one, is given in a dose of 20 international units per kilogram. This is per kilogram of body weight of the recipient, right? Now we come to anti-cervical cancer vaccines, 2 types, Cervarix, Gardasil. When we look at Cervarix, This is a bivalent vaccine. So logically it's going to include the two commonest HPV strains in our country, that is HPV 16 and 18. And 16 is most common cause of cervical cancer in our country. When we look at Gardasil, Gardasil is a type of quadrivalent vaccine. It has the commonest types HPV 16, 18 and the second most common types 6, 11 subtypes also. Please remember the target for HPV vaccine is late genes L1 and L2 genes. Subsequently, we also launched Gardasil 9 vaccine. Gardasil 9, as the name is telling you, it is a nonavalent type of vaccine. So this includes commonest HPV in our country 16, 18, second commonest 6, 11, third commonest 31, 33 and also 45, 52 and 58 subtypes of HPV. India also introduced a low cost Sarvavac vaccine through Government of India. This quadrivalent Sarvavac vaccine is likely to be available at a very nominal cost, maybe possibly free later also, in the National Immunization Schedule of India also. WHO SAGE criteria, Strategic Advisory Group of Experts on Immunization, they say 9 to 14 years of age, these girls require 1 to 2 doses of human papilloma virus vaccine. If the age of the girl is 15 to 20 years, then also 1 to 2 doses. But if age of the girl is more than 20 years of age, then this woman is going to require 2 doses. In cases of immunocompromised state, 3 doses should be administered to the woman. Cold chain maintenance of temperature of vaccines right from the point of manufacturing till the point of administration. Here we can study this in 5 different levels of our healthcare system. Now if you look, vaccines are stored in India up to primary health center level only. The most important component of cold chain in India is at PHC, ice lined refrigerator 2 to 8 degrees centigrade. At the same time, we have a deep freezer minus 15 to minus 25 degrees centigrade. This I am talking of is at primary health centers in our country. At district level, state, regional level also, we keep 2 such instruments separately. We have large ILR, again at plus 2 to plus 8 degrees centigrade, and large deep freezer, again at minus 15 to minus 25. ILR for all the vaccines and deep freezer for freezing the ice packs. State or regional level where we have to store lakhs and lakhs of doses, we require walk-in cold rooms 2 to 8 degrees centigrade for all the vaccines, walk-in freezers for freezing ice packs or storing OPV more than 3 months, minus 15 to minus 25. Storage duration is 1 month for all the vaccines at primary health center. It is 1 month at district level and 3 months at state and regional level. We do not store the vaccines at subcenter or village level. Rather, vaccines are transported in vaccine carrier at subcenter, which is able to maintain temperature plus 2 to plus 8 degrees centigrade, and at village level. Finally, when you are conducting immunization in a session, we use the smallest component of cold chain, that is fully frozen ice pack, to maintain the cold chain. Because vaccine storage is done till PHC, maximum chance of failure of cold chain is sub-center or below. Now going into the details of these components of cold chain, first we look at ILR, ice lined refrigerator. As I told you, this is the most important component of cold chain in our country, kept at primary health center, maintains a temperature of +2 to +8 degrees centigrade. Storage duration 1 month maximum at this most important component of cold chain. Now, what is the unique advantage of this particular instrument? That it requires electricity only 8 hours a day to maintain the temperature of vaccines. And without electricity, if there is a continuous interruption in the supply, it can maintain temperature of vaccines up to 5 days also. So these unique features make ice-lined refrigerator an important component. Now, after ice-lined refrigerator, we look at how the vaccines are actually stored in this. So when we look at ice-lined refrigerator kept at a primary health center in our country, we realize that upper part where temperature is closer to +6, +7, +8 degrees centigrade, we store T series of vaccines which are more thermostable, whereas the bottom part is meant for more thermolabile vaccines like BCG, OPV, measles, MR, MMR, Japanese encephalitis vaccine, etc. Diluent should be kept towards the top of the ice-lined refrigerator. Now, ice-lined refrigerator, you have to monitor temperature also. We use dial thermometer to monitor temperature of cold chain in a ice-lined refrigerator at a primary health center in our country. This dial thermometer is based on the principle of thermocouple, and the frequency of temperature monitoring is twice a day, morning, evening, morning, evening. Although it is recommended, alcohol stem thermometer is better than dial thermometer because it is more sensitive. But dial thermometer is a field instrument. It could be easily used if there is a color coded zone also +2 to +8 for a health worker also. Vaccine carrier. Instrument used to carry vaccine from primary health center to the sub-center or village for immunization purpose. Now, how many vaccine vials it can maintain the temperature of is 16 to 20. And how it is going to do that is by using 4 fully frozen ice packs. Please remember, if not unnecessarily opened, it can maintain temperature of all vaccines 12 to 24 hours. So we can keep it overnight at a sub-center. If it becomes delayed in the evening while carrying out the immunization session, there is no need to bring back the vaccine carrier to the PHC the same night. This is the smallest component of cold chain, a fully frozen ice pack. When we look at fully frozen ice pack, which is of different shapes, sizes, types in our country, please remember this ice pack, there is a horizontal level for filling up the water as ice expands on freezing. These holes are for keeping the vaccine vials during immunization, and it should be plain tap water, nothing mixed, which should be filled inside this ice pack. Open vial policy. If a vaccine vial is opened, all doses are not used, some are remaining after the session. If properly maintained in cold chain, it could be brought back to the ice-lined refrigerator of PHC, again taken for the next session. This we can maximum do up to 28 days as per the guidelines of National Immunization Schedule, RCH program, National Health Mission. Now, which vaccines This open vial policy is applicable. This is applicable on T series of vaccines, DPT, DT, TD, TT and hepatitis B. This is also applicable on oral polio vaccine, inactivated polio vaccine, Sabin and Salk vaccine respectively. Also, it is applicable on pentavalent vaccine which contains Haemophilus influenza B, pneumococcal vaccine also. Please remember, this open vial policy concept is not applicable. If doses are remaining, you have to discard those vials. These include lyophilized vaccines like BCG, measles, MR, MMR, Japanese encephalitis and rotaviral vaccine. COVID vaccines open vial policy is not applicable. Please remember. We look at now some common contraindications to vaccination, specific conditions. Pregnancy. All live vaccines are contraindicated. Why? Because pregnancy is an immunocompromised state. Live vaccines, live attenuated virus bacterium will act like a potent complete virus or bacterium. This has an exception of yellow fever vaccine. In contrast, during lactation, only yellow fever vaccine is contraindicated as it is excreted in breast milk. HIV positive status, again low immunity, CD4 count is low. All live vaccines are contraindicated. Please remember, if it is asymptomatic HIV positive adult, no contraindication. These live vaccines are contraindicated only in symptomatic HIV positive adult. Even in that, there are exceptions. MMR, zoster, varicella vaccine are 3 exceptions. Newborn, HIV positive. Symptoms or no symptoms, live vaccines are contraindicated except measles, OPV and BCG in India. Epilepsy, pertussis. If pertussis is not in the choice, we actually give it as a combination in DPT in our country. Cerebral palsy is non-progressive neurological disorder. There is no contraindication. Please remember, generally, diarrhea is not a contraindication for any vaccine. Even malnutrition is not a contraindication for any vaccine. And when we look at fever, then typhoid and COVID vaccines are contraindicated. Epidemics, all vaccines are contraindicated because they take time for immunity to form except measles. Because measles vaccine forms protection faster than the natural incubation period. Same reason, same answer for post-disaster situation also. Beyond contraindications, we look at FIs, where E is events. Adverse events following immunization, the observation period is generally 30 minutes for all the vaccines. When we look at paralysis, it can occur due to any vaccine, but mostly it is oral polio vaccine. 2 types it leads to. One is VAP, vaccine associated paralytic polio, most commonly due to P3. Vaccine derived poliovirus, most commonly due to C subtype of poliovirus type 2. When we look at hypersensitivity or shock, then mostly vaccine responsible is hepatitis B. Toxic shock syndrome, Staph aureus, it is due to lyophilized vaccines. Measles vaccine is the commonest culprit. Guillain-Barré syndrome occurs due to killed influenza or killed swine flu vaccine. Interception, potential life-threatening complication, rotaviral vaccine. Persistent crying, again pertussis, DPT. Hypotensive hyporesponsive episode, again DPT. Please remember, pertussis is very neurotoxic. If any serious side effect occurs like high temperature, persistent crying, collapse, anaphylaxis, shock, then it subsequently should not be given. Not given means pertussis should not be given. It should be replaced with DT. From DPT, we take out pertussis at 10 and 14 weeks and subsequent doses. Please remember, if the gap is more than the suggested 1 month gap between successive doses of DPT, Do not restart the schedule. Continue from where you left. Also remember, whereas fever, when we look at most commonly associated vaccine is pertussis DPT, febrile seizures mostly occur due to measles vaccine, thrombocytopenia, MMR and hepatitis B. And friends, please remember, exams are not about finding who is the best, but rather it is about evaluating who can handle the pressure best. So at the time of the examination, you have to maintain your calm and composure, focus on your strengths, focus on the hard work you have put, and definitely you will attain the desired result and success that you want. Let's move to the next topic, screening of disease. Now, what is the meaning of the word screening itself? Screening itself means search for an unrecognized disease or defect. That means person may not even be aware that he is having disease in apparently healthy. Please remember, I am not saying healthy, but people who appear healthy. And how do we do this? This is by means of rapidly applied test. Now look carefully, you are trying to detect the disease. So this is which level of prevention? Very right, screening of disease is secondary level of prevention. So on apparently healthy people, we apply screening test. It's not always accurate, but those who come positive, those will be subjected to diagnostic test now. Now screening, two types of classifications are asked in detail. Let's look at them one by one. First classification divides screening into prescriptive and prospective. What is prescriptive screening? Prescriptive screening, when you write prescription to a patient, it is going to benefit that patient. So it is done for one's own benefit. Take an example, pap smear. When you do pap smear in a woman, it is going to benefit that woman only. Detect cervical cancer in early stages, in situ stage 1, early initiation of treatment, better prognosis, better survival. In comparison, pros means others. So this is done for others' benefit. Take an example, look at immigrant screening. When an immigrant is screened at an airport, then the authorities are actually not so much concerned about immigrant. They don't want the immigrant to bring a new disease to their country. So it is done for the benefit of population of that country, not for immigrants' benefit. Diabetes mellitus screening test is, yes, random blood sugar. So that should be a type of, yes, prescriptive screening. So diabetes mellitus, when we screen through random blood sugar, it is going to benefit that person only. Early detection, better treatment, better prognosis, better survival. Then when we look at HIV screening, it is a type of, yes, it can fall in both. But single best answer, HIV screening is mainly a type of prescriptive in nature. Is my patient having HIV? Do I need to start treatment? Do I need to give prophylaxis to prevent opportunistic infections? HIV screening before blood transfusion? Yes, that is prospective. We don't want a healthy recipient should get HIV positive blood due to our mistake, right? HIV screening among commercial sex worker, again prospective. It is for the benefit of the client population that we test HIV in commercial sex worker. Levels of prevention they represent. Yes, prescriptive screening is secondary level of prevention. You are detecting the disease to treat and benefit that patient. But prospective screening is primary in nature. It is specific protection for someone else. So screening overall secondary, but prescriptive is secondary, prospective is primary. Second classification of screening divides it into 5 different subtypes. A question was asked, annual health checkup is a type of multiphasic screening. So let us look at these one by one. We first look at mass screening like chest X-ray in elderly. So it is applied to larger populations. So mass populations. So this is a good screening test for lung cancer in the country. High risk screening, as the word is telling you, it is done in high risk groups, so also known as selective screening. A good example could be screening of HIV in commercial sex workers, where we know they are at high risk, higher prevalence is likely to be found. Multiphasic, multi-purpose, you have to differentiate clearly. What is multiphasic screening? Multiphasic screening is more than 2 tests to large number of people. I told you the question asked in your exam. Annual health checkup is a type of. So what we say, after the age of 45 years, people should undergo multiphasic screening. So we use hemogram, LFT, KFT, urine analysis, chest X-ray and ECG minimum as a part of these routine checkups. What is multi-purpose then? Multi-purpose screening is where more than one test is applied to detect more than one disease. This is found in, yes, a good example could be RCH program of India. Pregnant females, we test for HIV, HBV, HCV in pregnant females from the single blood sample. Opportunistic screening, otherwise difficult to screen, but when an opportunity arises, like you must remember rheumatic fever is found in which age group? Older PYQ? Yes, it is 5 to 15 years. So if you go house to house, it's difficult to trace them. But if you can do rheumatic fever, RHT screening in schools, that is an opportunity. Look at this diagram. This represents, yes, natural history of disease, progression of a disease without any intervention. Now look at these points. Let's label them also. Point A, B, C, D and E. To be effective, a screening test should be applied between A and B, B and C, C and D, D and E. Yes, between B and C. Now why not A and B? Why not A and B? Because it is not possible many times. Why not C and D? Because after critical point is passed, treatment will not give desired benefit. So it has to be between B and C. This is the reason this point, B to C point, is known as, yes, this is known as screening time. Now what is the advantage of doing screening? Early detection, better treatment, better prognosis, better survival. Look at the screen carefully. Suppose a female comes to your OPD today 2025 with jaundice, metastasis in liver, you find cervical cancer stage 4. Maybe with your treatment she will survive for another 2 years. But suppose the same female came to you 10 years earlier. She came to you in 2015 when she was apparently healthy. You use Pap-smear. So you will be able to detect the disease much earlier here. In case she didn't come for screening, she directly comes with the signs, symptoms or progression of disease. You will detect disease here 2025. So what is this gap known as? This gap without screening when you will detect, with screening when you will detect, is known as lead time. This is advantage gained by a screening test. So early detection, better treatment, better prognosis, better survival. So this is your lead time. Now let us look at these tests one by one. Look at this one. This is, yes, Pap-smear, the screening test for cervical cancer in our country. If you see carefully, this instrument is Ayer's spatula. Screening test of cervical cancer in India, primary test was Pap-smear. Pap-smear is now number 2 test in the country. Number 1 test is, yes, this is wire test. What is wire test, friends? Visual inspection of cervix with 5% acetic acid. This is now the test of choice for screening of cervical cancer in the country. It is the most cost effective test in India. It is also the recommended test of choice in resource limiting developing countries. It is such a easy test, it could be done at a primary level of healthcare also. Also, we can use Villi test. Visual inspection of cervix with Lugol's iodine. Now, please remember, after the screening test is done and it comes positive, diagnosis is confirmed by colposcopic punch biopsy. For cervical cancer in the country, this is yes, mammography. It is the screening test of choice for, yes, it is the screening test of choice for breast cancer in our population. Now, mammography is such a good test, but it comes with a problem related to age of the woman, that it is not useful in younger age below 40 years. And breast cancer has a bimodal distribution. It is seen in older female also, younger female also. So, in younger females, where we cannot do mammography, we rely upon other methods. Ideal is MRI. So, MRI is best test in younger females, most sensitive. Not possible, then ultrasonography, thermography, palpation by a physician or surgeon. If nothing is available, breast self-examination, high false positive, high false negative. Even then it is recommended as a screening test in developing countries like India. But overall, no doubt, mammography is the test of choice. This is, read carefully the slide, which test shown in this particular image, that is the diagnostic test for diabetes mellitus, oral glucose tolerance test. Now friends, please remember, there are 3 tests for diagnosis of diabetes in our country. First is, if fasting blood sugar is more than 126 milligram percent or milligram per deciliter. Second is, HbA1c glycosylated hemoglobin level is more than 6.5%. And third diagnostic test is oral glucose tolerance test, where we measure venous plasma glucose level. And what is the cutoff? For this cutoff, we choose 2-hour reading. So you take multiple readings, baseline, half hour, 1 hour, 1.5 hour, 2 hours, or even later. But for diagnosis, we take 2-hour reading. If it is more than 200 milligram per deciliter, that is a confirmatory of diabetes mellitus. Treatment should be started. So look at the image carefully. Patient number 1, patient number 2. Because they were more than 200 at 2 hours, both of them would be declared as diabetes positive. You have to start their treatment. But look at other patients at the bottom, 3, 4, 5. Irrespective of their previous reading, they were found to have below 200 at 2 hours. So they would be declared non-diabetic. This is, yes, Mycobacterium tuberculosis. And what is the diagnostic test for Mycobacterium tuberculosis in the country? We use sputum smear for acid fast bacilli, where the stain used is Zn stain. And how do you identify the bacilli? They are mostly single acid fast, red colored, rod shaped, as you can see in the image, having a typical appearance like this. You can see here, this one, this one. This is typically known as beaded appearance. And what is the chemical composition of this bead? It contains mycolic acid. So it stains faster and deeper than rest of the bacilli. Also remember, minimum bacillary load required for Zn stain to show acid fast bacilli of TB is 10 raised to power 4, 10,000 bacilli per ml of sputum. This is yes. Now suppose I ask you which screening test is better in HIV? ELISA, rapid, simple. There are three tests, ERS, battery. Then how will you compare and contrast ELISA, rapid, simple? We use properties of screening test for which you need 2 by 2 table. So we always have disease on top, disease present, disease absent. On the left side of the table is screening test results, whether they come positive or negative. Then this is your A, B, C and D. This is exactly similar to table of yes, case control study. So first column is having the disease cases, second column is not having the disease controls. If you look carefully, A is having the disease test positive, true positive. Look at D, disease absent test negative, true negative. This is what we want from a screening test. But errors are there, errors are always there, B and C. B, HIV disease like HIV absent but screening test like ELISA comes positive. So this is false positive. And C, HIV present but ELISA comes negative, false negative. False negative is a more serious error in cases of diseases like HIV and cancers. Now to understand these properties, we have to memorize formulae. Let's look at them. When I look at sensitivity of a screening test, it is A upon A plus C into 100. True positive upon true positive plus false negative into 100. Specificity, D upon B plus D into 100. True negative upon true negative plus false positive into 100. PPV, positive predictive value, A upon A plus B into 100. True positive upon true positive plus false positive into 100. NPV, negative predictive value, it is D upon C plus D into 100. Now please remember, when we look at sensitivity carefully, you will realize sensitivity is true positive out of those people having the disease. If you look at specificity, this is true negative out of total people who are healthy not having the disease. PPV, it is those who are positive out of total positive. Negative predictive value who are negative in reality, healthy out of total negative. So let me repeat, positive out of diseased, sensitivity. Diseased out of positive, positive predictive value. And those who are diseased also, positive also, they are true positive in the population. Please remember, most useful property of a screening test is yes, sensitivity. So higher the sensitivity, more people we can send for diagnostic confirmation. Diagnostic power of a screening test is given by PPV. So PPV is diagnostic power of a test. Similarly, NPV is diagnostic power of a screening test to correctly exclude a disease in the question. Please remember, sensitivity is generally inversely related to specificity and PPV is generally inversely related to negative predictive value. PPV is directly proportional to prevalence and negative predictive value is inversely proportional to this prevalence. If you see carefully, this graph is drawn between sensitivity and 1 minus specificity. Or I can say in other words, true positive rate and false positive rate. This is known as ROC curve, receiver operator characteristic curve. Now I told you what is the relationship between sensitivity, specificity. They are inverse of each other. If you increase one, other will decrease and vice versa. So we have to strike a balance between them. That balance is struck by ROC curve. So ROC curve is used for trading off between sensitivity and specificity. Now how to interpret the given ROC curve? Plot all the screening tests for the same disease on the same graph, or maybe different cutoffs on the same graph. If line is straight at 45 degree, Z line, or it is in the lower quadrant, this test is of no use. This cutoff is of no use. But higher the curve, better the test. So Y is a fair test or fair cutoff. X is the best test. That should be chosen as a test of choice between them. Look at this graph. What does it tell you? With time, how the survival probability is reducing. So this is survival analysis, generally used for cancers and chronic diseases. We follow up the patients every 5 years. Out of the original 100%, how many survive every year? So this particular graph used for survival analysis is known as KM, Kaplan-Meier curve. Now in this particular graph, if you look, there are two lines. Green line, if you look, that is every patient is dying before 25 years of diagnosis. Whereas when you look at blue line, you can see almost 50% survival is there even after 35 years. So what these two lines separately represent? Green line is without treatment and blue line is with treatment. So now you can interpret this Kaplan-Meier curve for this particular disease. Is treatment beneficial in this condition? Yes. Without treatment, everyone dies, 100% mortality in 25 years. Whereas with treatment, 50% survival even after 35 years. So definitely there is a better chance of survival with treatment. So bigger the gap between these two curves, more beneficial the treatment is. If these two curves are running side by side, then that is not going to give a very good desired benefit in terms of survival. Now also remember, if you are shown for this graph, it's 95% confidence interval bands. So which bands are used? These are Hall-Wellner bands. Or we can use Nayer's equal precision bands. That is for 95% confidence intervals of these survival curves. Now let us look at what is the difference between precision and accuracy. Now definition wise, precision is repeatability. So when a test is giving same value again and again, also known as consistency of test, reproducibility of test. In current language, this is known as reliability. A test is coming same again and again, but it is actually correct. That is accuracy. How much close it is to true value. This accuracy nowadays has been replaced by the term validity. So if someone is giving same reading on blood pressure apparatus again and again, that is precision. Is that value representing the actual BP of the patient? Then it is accurate also. Now please remember, LJ curve is used for LJ curve, Levi-Jennings chart is a measure of accuracy. Loss of precision but it is mainly a test of accuracy. We can also use mean chart and Sheward control chart for accuracy. Precision we can measure by R chart and range chart. Now please remember, when you look at validity subtypes, if I look at now validity as a topic, it is of many types. So we have internal validity, external validity, content validity, phase logical validity. We also have criterion validity. Now we have to understand the meaning of these terms. Internal validity is trustworthiness of the result. You have done a study. How much results are going to be trustworthy based on how you have conducted the study. Whether you can generalize your results to external settings and others. This extrapolation is external validity. So this is generalizability of the results. Now, among all the types of validity, best measure of validity is criterion validity. In this criterion validity, we compare your given test versus gold standard. And how do we measure this? It is measured in terms of sensitivity and specificity. Also remember, as per Bayes theorem, positive predictive value depends on three parameters, that is sensitivity, specificity and prevalence of a disease in the given population for which that particular test is used. So it is given by the formula sensitivity into prevalence divided by same sensitivity into prevalence plus 1 minus specificity into 1 minus prevalence. Close the bracket, multiplier is 100. For calculation purposes, please use instead of 100 in the denominator, apply everything in percentage directly. Also remember, prevalence is pre-test probability of a disease in the population, whereas PPV is post-test probability of the same disease in the same population. Let us now move to communicable diseases and non-communicable diseases. We start with the basic epidemiology. Incubation periods of few important diseases. Incubation period, entry of organism till appearance of first sign or symptom. Commonest asked disease is measles. Incubation period is 10 to 14 days. If you are asked single answer, in case of measles, this is actually not minimum to maximum, but on 10th day fever starts, 14th day rash starts. Therefore, single best answer is 10 days. When we look at influenza, it is 18 to 72 hours. 1 to 3 days, and diphtheria is 2 to 6 days. Typhoid has an incubation period of 10 to 14 days like measles. Cholera very short incubation period of 1 to 2 days. Polio 4 minimum, 33 maximum days. If it is not given in the choices, average is around 7 to 14 days. Most common food poisoning of India, staphylococcal food poisoning, single exposure point source epidemic, incubation period is yes 1 to 6 hours. Now when we look at infectious hepatitis, hepatitis A, then fecal route of transmission, this has an incubation period of 15 to 45 days, 2 to 6 weeks. Hepatitis B, serum hepatitis, is 45 to 180 days, 6 weeks to 6 months. Dengue, incubation period is 3 to 10 days. And malaria, when we look at commonest falciparum, median incubation period is 12 days. Yellow fever incubation period is exactly similar to diphtheria. So it is 2 to 6 days. For yellow fever, what is the quarantineable period? Period of quarantine for yellow fever disease is 6 days. Why 6 days? Because quarantine is done for the maximum incubation period of the disease. Japanese encephalitis incubation period is 5 to 15 days. Now looking at the two recent diseases, one Ebola and the latest most pandemic COVID-19. Ebola incubation period is 2 to 21 days. COVID-19 is 1 to 14 days, on an average 5 to 6 days, 5.1 day median incubation period. Now let's look at some commonly asked diseases beyond these. Trachoma, 5 to 12 days, a disease of low infectivity. Tetanus, also known as 8th day disease because incubation period is 8 days, 6 to 10 days. HIV is very variable, months since years and decades it goes, but on median basis in India it is 10 years. Leprosy again 2 months to 30 years, but median incubation period, like for HIV it is 10 years, for leprosy it is 5 years. Periods of communicability. Measles, chickenpox are frequently asked. Please remember, chickenpox is 25, measles is 45. What does it mean? Chickenpox is 2 days prior to appearance of rash till 5 days later. Measles is 4 days prior to appearance of rash till 5 days later. Diphtheria is 14 to 28 days from the onset of the disease. How long a TB case is communicable to others? As long as treatment is not started. HIV, we have no currently cure available, so it is a lifelong communicability. Tetanus, a communicable disease, has no period of communicability. As it is not communicable from man to man, it is only communicable from soil to man. When we look at COVID-19, the new disease, although it has not been confirmed fully yet, but approximately the period of communicability is 3 to 5 days prior to symptoms till 8 to 10 days after that. Now friends, you tell me, how do we measure this period of communicability for a given disease? What is the best indicator use? We use secondary attack rate. How to calculate that? It is total number of secondary cases that develop within one incubation period divided by total number of susceptibles. Susceptibles will include those who have been infected earlier if they have lifelong immunity, or those who have been immunized earlier if they have immunity. Multiplier is 100. Answer will be in percentage. Secondary attack rate is not a rate, it is a misnomer, it is a proportion. Like secondary attack rate for measles is 90%, chickenpox is 90%, mumps is 86%. Eradicated disease smallpox, that was variola major, eradicated 8th May 1980. Its secondary attack rate was only 30 to 40%. What is this? This is iceberg phenomena of disease. If you consider iceberg to be a disease, we know iceberg has small tip visible above the water surface, maybe 8 to 10 to 20%. but the major portion is the hidden or the submerged part. Now, if both are having disease, what does tip represent? Tip actually represent your clinical cases. So, it is your responsibility as a clinician to diagnose them when they come to you with signs and symptoms. In contrast, look at hidden portion of the iceberg. This is not visible to you as a doctor because they may be appearing healthy, they do not have signs and symptoms. So this is actually comprising of carriers, subclinical, preclinical, asymptomatic, pre-symptomatic, latent. This is the responsibility of epidemiologists to find out. Otherwise, they also keep on spreading disease in the population. And how will epidemiologists find out these hidden cases in apparently healthy people? Very right, through screening. So, which level of prevention they individually represent? I told you both diagnosis as well as screening represent secondary level of prevention. This is line of demarcation, water surface, which lies between apparent and inapparent infections. Most of the diseases show iceberg phenomena, but best is shown by malnutrition, anemia. Even HIV shows a iceberg phenomena, but it is not seen in diseases generally where there are no carriers or very few carriers, like measles, rubella, rabies, tetanus, plus minus pertussis. Iceberg phenomena of disease. Now let us start with respiratory infections. Can you identify which of them represent which? First one is smallpox and second one is chickenpox. How did you differentiate that first is smallpox and it is second which is chickenpox? It is based on distribution of the rash. Look at first one. Smallpox has centrifugal distribution, whereas chickenpox rash is in the central part of the body. This is more centripetal distribution. Chickenpox varicella. The rash is characterized by two important properties besides centripetal distribution. One, it shows a dewdrop on rose petal appearance, as it is seen in this particular image, and it also shows pleomorphism. What is pleomorphism? Different stages of rash seen on same person's body at the same time. Smallpox, which used to be caused by variola major, last case 1977 Somalia, finally on 8th of May 1980 WHO declared global eradication of smallpox. Currently, smallpox is considered category A bioterrorism agent, most dangerous bioterrorism agent. What these two represent? Let's look at the first image, make a clinical diagnosis. This is measles. Now, you tell me, dear students, why I am calling this is measles and not any other disease? Because this is showing the pathognomic clinical feature, Koplik spot, bluish white spot opposite second molar in the buccal mucosa. Koplik spots are generally not seen in clinical practice. They disappear 2 days prior to appearance of rash. So how do you identify actually clinically measles? It is by its retroauricular origin of rash. Mother will typically give you a history of rash starting behind the ear pinna near the hairline, then it come forward and then it will go downwards, right? Measles. Measles, a disease of high infectivity, secondary attack rate 90%. Second image tells you a clinical diagnosis you can make is mumps. Now, why mumps? We are making a clinical diagnosis. Mumps is caused by myxovirus parootitis, and the commonest organ affected is salivary glands, especially parotid gland. Now, when I look at mumps and measles and compare their most common complication, measles, the most common complication is serous otitis media. Its least common complication is SSPE, subacute sclerosing panencephalitis, generally occurs 7 to 10 years after the initial infection. Please remember, in measles, maximum deaths occur due to secondary bacterial infections or pneumonia. In contrast, mumps, children, the most common complication is aseptic meningitis. In adolescents, it is orchitis in males, uveitis in females. In adults, it's meningoencephalomyelitis, but overall aseptic meningitis. Now, measles we call as rubella. Mumps we call as rubella. We have their third counterpart, rubella. So, when we look at rubella, also known as German measles, it is also a respiratory disease, but it can also be transmitted mother to child. First trimester is most common time of transmission, also most dangerous also. So, if it transmits in first trimester, it may lead to congenital rubella syndrome with all three clinical manifestations. What are these three? One is sensory neural deafness. There is microcephaly also. Second is heart defect. PDA is most common. And third is cataract. Blueberry muffin lesions you must have known. Vaccine rubella is a live attenuated vaccine. It is lyophilized, which is reconstituted with distilled water or sterile water, and its strain is RA27/3, should be used within 4 hours of reconstitution like any other lyophilized vaccine. This is, we are giving intranasal vaccine. So, which vaccine are we talking of? Earlier, the intranasal vaccine which was used in India was mainly killed influenza vaccine or live influenza vaccine. This is, yes, live influenza vaccine. Now, influenza vaccine given intranasally. Now, we also have intranasal COVID vaccine Incovac. When we look at the disease influenza,